until they have higher costs to get insurance. But there are other steps that can be taken to address it, like paying plans more if they are able to attract and keep happy people who have chronic diseases, who have the most to gain from those kinds of coordinated care steps. So there are some reforms that could be implemented to get, I think, those administrative costs way down. And I totally agree with you. That's got to be a big part of our solution to the healthcare coverage problems in this country. See, I'm sure where you want to go next. Who's maybe down here in front?
I can speak up.
Okay. I think they want your voice for posterity, though.
So you've talked about, I mean, you started off talking about some of the problems with the American healthcare system, and I'm sure, there are lots of statistics for this, how our population outcomes like infant mortality are really slipping compared to Western European countries. And you've talked about a lot of promising programs to change funding with group practices that can really both improve access and reduce costs. But you also mentioned that the Dartmouth research showing the fragmentation of the American healthcare system. At what point should we still be talking about reform, and at what point should we be talking about how our system is? Where do we draw the line when our system's no longer working and it's not anymore a question of reforming things, but a question of creating a new healthcare system?
Well, I think that I don't know that you need to draw the line. I think the question is how can we get better results for our population as effectively as possible? And I think those go into, your question actually opens up a whole new area. One area is making our healthcare systems work better. And as I try to talk about tonight, we're getting what we pay for. If we pay more for more complications, if we pay more in these areas where Dartmouth has found costs to be higher. And then, the Dartmouth research, they're great. They've been documenting this for 30 years now, and it just keeps getting bigger. And if we keep paying more for that, then of course that's what we're going to get. In contrast, if we pay more for better care at a lower cost, better results at a lower cost, I think there's growing evidence that that's what we'll get as well. But a lot of the kind of statistics that you're talking about, like infant mortality and overall population mortality rates for that matter, really are driven by things that go way beyond healthcare. And it's not healthcare differences that account for that. I think according to one of the studies published in JAMA last year, some of the wealthiest groups of Americans who don't seem to have much trouble with access to healthcare at all have worse health outcomes than middle class or even lower middle class people in other countries. And this is driven by other things. And while it's been hard to get a handle on, things like education and personal preferences about risk and other types of personal behaviors, environmental factors, things that go way beyond our healthcare system are primarily responsible. The Robert Wood Johnson Foundation is about to launch a new commission week after next, which I'm a part of, that is going to try to put a much bigger spotlight on these non-healthcare factors that seem to be playing a big role in the worst